We're really excited about the tremendous turnout we've had for this webinar. So we've got people in 17 countries wanting to join us for this webinar. So that's a pretty amazing amount of interest in SIBO right now. If you're a patient and you are listening in on this, please be aware that you should still use the guidance of your practitioners for breath test interpretation. This is a webinar for practitioners to help them really understand what the nuances are of different breath test interpretation. What we're going to be doing is we'll be talking about the basics of breath testing, also about the prep diet, very important, prior to testing. Then we'll go through the different test result interpretations and common patterns that you'll see. And then at the end, we'll be taking some question and answers. So hydrogen and methane-based breath testing has come really a long way, even in the last 5 years or so. There's always been a little bit of a controversy around how effective or how accurate breath testing is for the interpretation and assessment of SIBO. And we finally have a consensus that's come out of the North American consensus that breath testing is a useful, inexpensive, simple, and safe diagnostic test in the evaluation of common gastroenterology problems. So we'll be going through the different substrates and testing methods here tonight. So a word about testing in general, that stool test which is often used by health practitioners and by naturopathic physicians and other health practitioners, but stool tests are not accurate for SIBO. They will not tell us what type of fermentation is happening in the small intestine. So the only test that's that's available to us is really the breath test. And bacterial fermentation is measured over 90 to 100 minutes and measures methane and hydrogen gas. These gases are not produced by humans. And when we talk about the different types of SIBO, we have SIBO-D or diarrhea dominant, and that's predominantly caused by E. coli, Klebsiella, Proteus, Aeromonas, and those are the most common ones, but of course we have different bacteria as well, but these particular bacteria tend to produce hydrogen. When we talk about constipation dominant SIBO or SIBO-C, it's mainly Methanobrevibacter smithii that produces this gas, methane gas, which is quite constipating in general. But what is a breath test? So if we look here on the right, we ingest the substrate, or the patient ingests the substrate, and it's either lactulose or glucose or fructose or another less used test substrate called D-xylose. And what happens is bacteria that are in the wrong location or in the small intestine are fermenting that substrate into hydrogen or methane. There is a third gas, hydrogen sulfide, that it cannot be assessed using the breath tracker at this time. These two gases are absorbed into circulation through the digestive tract, absorbed into the circulation there, and it's carried to the lungs where these gases are then exhaled and can be captured in a breath sample collection. So if you're in one of the 17 countries that is joining us tonight, there are different types of labs that have different methods and different guidelines. But the consensus now clearly states that there are certain things that you should ask for as the discerning practitioner. First of all, how restrictive is the prep diet? And the prep diet really is there so that the bacteria fermentation is reduced the day before, so that by the time the test is being performed, bacterial count has been reduced, or production or fermentation has been reduced, so that by the time the substrate is used, excuse me, we actually have a more accurate measurement over baseline, and we'll go through that in just a minute. So prep diet restriction is important, and also to ask if they use a open or closed sample collection system. And here at SIBO-Test, we use the vacuum tubes, so the vacutainers that have a vacuum in the collection tube, and this allows for a mid-breath collection. There are other older types of collection bags where the patient blows into a bag and then has to use the stopper to close the bag. So we think that the closed sample collection system basically has a little bit less error in collection. Also, you want to ask if your lab tests for hydrogen, methane, and carbon dioxide. That's very important because carbon dioxide is used as a measurement to see if that sample was viable or if that was contaminated with room air. So it's a really, really good measurement, and you will see some test results a little bit later on where a sample was incorrectly collected and is flagged for the practitioner. And then grams of test sugars. This is very important. And I often see patients that come in with test results that have been performed by different labs, and the grams of substrate were incorrect. And especially with lactulose, that is a big deal because lactulose is also a laxative. And so if you take more than 10 grams of lactulose, it's possible that you can end up with a much more rapid transit, and that will skew the results. With glucose, typically it's about 70 grams, 75 grams, the package that's in the test kit, and then the patient has to do a little bit of calculation to arrive at the correct grammage for their substrate. And then 25 grams of fructose is used. So ask your lab those questions. And then also really important is the sample timing. If you can imagine if you use a 20-minute versus a 30-minute interval, as we'll see in a moment, that could potentially miss certain positive test results. So typically the samples are collected after the baseline every 20 minutes for 3 hours. The length of test, 2 hours versus 3 hours. This is what we find is important, is to demonstrate that after the substrate has cleared the small intestine, that it arrives in the large intestine, because we do want to see some fermentation happening, and that ensures that it gives us a better idea that that substrate has arrived in the colon. And so a 2 hour test is sometimes not long enough to really demonstrate that. But the window of testing, or the window of opportunity for testing for SIBO, is somewhere between 90 and 100 minutes. There are other labs that interpret 120 minutes, up to 120 minutes, and that's sort of a transition zone between the small and the large intestine. So preparing for the test, these are guidelines that you're welcome to download from SIBO-Test, and also use, you can give that to your patient even if they're using other test guidelines from labs. And we found that we've sort of looked at all different types of testing preparation guidelines, and they're ranged from very, very very restricted to not at all restricted. And so you're going to have quite a difference in baseline readings. The more or the less restricted you are, the more higher we find the baseline will be. So we're big fans of very strict preparation guidelines. And that extends beyond just what they eat the day before. It also is about what they what kinds of medication and types of supplements they can use for up to a month before the test. And so these are the things to avoid a month prior to testing. That's a colonoscopy. It's much better to wait a month before you do or recommend a breath test to your patient. Antibiotics, unless you're retesting. So, for example, if you've had a patient that you've treated, you've tested before, they're positive, you've put them on rifaximin, you want to retest them the day after they stop the rifaximin. So the antibiotics is more for if they've taken something for something unrelated, and this is your first test of for SIBO. 1 week prior to testing, you want to stop all probiotics or recommend that the patient stops all probiotics. And this is important because if you're asking your patient to do a breath test and they are time poor and then they get the test kit and they've just find out that they have to wait another week because they're still taking probiotics, this is how you can really help out your patient. The probiotics also include fermented foods. And also herbal antimicrobials, but the same guidelines exist as for antibiotics, and that is you can retest the day after you stop herbal antimicrobials if you've done that for SIBO. 1 day prior to testing, you want to stop laxatives. So if your patient is extremely constipated, you can still use magnesium or those other some more milder laxatives, but anything quite purgative you don't want to recommend to your patient. You also want to stop all digestive aids like hydrochloric acid or enzymes. Also note that proton pump inhibitors are no longer necessary to be discontinued prior to testing. The PrEP diet is a 12-hour overnight fast, and then the patient commences testing the next day. If they're constipated or have more of a constipation dominant picture, you want to recommend that they do 2 days of PrEP dieting prior to testing. And the PrEP diet is based on extremely very low FODMAP, but the patient doesn't have to consume all of these foods below, but they typically consist of basmati or jasmine rice, chicken or turkey, eggs, Parmesan cheese, coconut or olive oil, and salt and pepper. So this is quite a restricted diet for 1 or 2 days. So this is a common question that we get at SIBO test is what test do I order for my patient? And the primary test is the lactulose breath test. But not every bacteria ferments lactulose equally. So this is a really important concept, is that if you get a negative lactulose breath test and yet your patient is fitting very much the symptom picture of SIBO, they could still have SIBO. And it's possible that they're not really fermenting the lactulose, or the bacteria in the small intestine are not fermenting lactulose. So we often recommend that if you want to have the most accurate test results or the most possibility of a positive result, you can use different substrates in conjunction with lactulose, and these are done on consecutive days. So the patient would order a lactulose-glucose combination, they do lactulose the first day, return to the PrEP diet, and the next day they would perform the glucose breath test. Glucose is actually an excellent test substrate, but it does get absorbed in the first part of the small intestine and can therefore be leading you to a negative test result if that patient has SIBO or small intestinal bacterial overgrowth in the last part of the small intestine or the distal small intestine. So it is not completely foolproof, and certainly we don't recommend just glucose testing because of this phenomenon of rapid absorption in the proximal small intestine. Fructose has been sort of used as a substrate. It is definitely a substrate as well to test for SIBO. And it's been recommended that if you're looking for fructose malabsorption, it's a substrate that's used also to diagnose fructose malabsorption, which is partially a genetic condition. That you actually treat SIBO first before you use fructose to test for true fructose malabsorption, because it's likely that if SIBO is still present, that you will capture SIBO rather than true fructose malabsorption with the fructose substrate. All right, so let's move on to interpreting the test results. As I've mentioned, the testing window is 90 to 100 minutes from the beginning of the test. And we'll see in a moment what these test results look like, and it's going to be a lot easier for you to visualize. From 100 to 120 minutes, that's more of a transition zone into the large intestine. And so we often we mark that as borderline if we do see a rise in that time frame. And we leave that up to the practitioner to interpret based on their patient's presentation. After 120 minutes, a rise in either hydrogen or methane is likely due to the large intestinal contribution or bacterial fermentation in the large intestine. Tests can be positive for hydrogen, methane, or a combined hydrogen-methane, as we'll see in a moment. Lactulose and glucose have slightly different parameters for testing positive. So hydrogen will be positive with a rise of 20 parts per million over the lowest preceding level. And I basically have written this out so that you can, for people that are more of a visual, can actually see the numbers, but we'll see this a lot more clearly in the test results in a moment. So 20 parts per million over baseline or over the lowest preceding level, so I'm sorry, for lactulose, but only 12 parts per million of a rise for glucose. Methane is positive with a rise of 12 parts per million over the lowest preceding level by 90 to 100 minutes for both lactulose and glucose. And the combined hydrogen and methane levels, lactulose is 15 parts per million and glucose is 12 parts per million. Okay, so let's get into some test results here so that we can, so you might have to get your reading glasses out because it's a little bit hard to read, but this is a classic test result and I've marked the different columns. I'm hoping that you can see my mouse. So we have the sample here. On the left-hand column, we have the number of test tubes, and it starts with sample number 1, which is always the baseline. So this is when the patient has gotten up after an overnight fast, and they proceed with testing or collecting their first sample before they consume the substrate. So we want to see what's actually happening before we challenge with a substrate. So here we see hydrogen levels at 1 at baseline. And so if we say that, okay, so we want to see 20 parts per million of a rise by 100 minutes, which is sample number 6. We see this very clearly demonstrated at sample number 4 at the 60 minutes. The gas levels go up to 22. So we see a rise of 21 parts per million. And in this case, it continues up to about 89 in that whole testing window. But by then, you already know it's quite positive. For methane, we want to see a rise of 12 parts per million. And in this case, we do see that we take the lowest preceding value, which is 18, and we want to see a rise of 12, which is clearly the case by sample number 5 here at the 80-minute mark. So we go from 18 to 48, which is a rise of 30 parts per million. And the combined, we want to see a 15 rise, and we do see this here as well. So in all 3 cases here, we captured a positive test result. And it's good to know the numbers, and it'll be written up, of course, in your reports so that you can interpret it yourself. But we sometimes see, very frequently actually, we see test results where only hydrogen is positive, or only methane, or only the combined. So in this case, this is a very clear-cut case, but in future patients that you may see, you may actually only see one of these categories be positive. This is a lactulose and glucose breath test positive in the same patient. So this is a very good example of where, okay, you've done a lactulose and you've asked them also to do a glucose, and it happens that both test results are positive and confirming certainly that this patient has SIBO. So once again, we take the lowest preceding level of hydrogen, which is in this case the baseline, and we look at 100 minutes and we want to see a rise of 20 parts per million, and that is the case with this patient. Same with the combined. And then we see the glucose, this phenomenon that I said that glucose is rapidly absorbed is very well demonstrated here, where we actually start with a baseline of 12 and we go up to 33. That's certainly a rise greater than 12 parts per million in order to be positive. So, and then you see with this curved graph up at the top here how that glucose is rapidly absorbed as it reaches even 80-minute mark. It's practically gone. So in this case, both lactulose and glucose breath tests confirmed that this patient has SIBO. Here's a case where in the same patient, the lactulose test is negative, but the glucose result is positive. So we see here on the left a baseline of hydrogen, and it doesn't really go up to 25 until 180 minutes, and that's 3 hours. That's certainly where the lactulose has reached the large intestine. So this is a negative test result for both hydrogen, methane, and the combined category. So if that practitioner had only done lactulose, would have missed this particular case of SIBO, because following that test the next day, this patient did a glucose test and started off with 5 and went up to 22. So that's a positive. It actually, so positive right here at 60 minutes, certainly even more positive at 80 minutes on a glucose test. And so I don't always recommend doing lactulose. I think that lactulose and glucose rather. I often just do lactulose. And then because you can always, if you're concerned or if your patient has a test result that doesn't really match their pictures, you can always do a confirmatory glucose later. When you do buy them combined though, you do get quite a substantial discount. So some people opt for that. This is a methane positive test. So classic SIBO positive if by 90 to 100 minutes you see a rise of methane of 12 parts per million. So here we have the hydrogen column, which is completely negative, and we see methane go from 39 baseline, and you will see that patients just have high baselines or have a high level of methane that is high and stays high throughout the test. And so we see a rise of almost 30 by 20 minutes, which is tremendously positive. And also in the combined. So this is a SIBO positive for methane. We do, however, have a methane conundrum, as I like to call it, and that is that high methane throughout breath testing is likely also to be large intestinal overgrowth, or what we call a bloom of Methanobrevibacter smithii. It's quite common to have that in the colon, actually, and a lot of people have Methanobrevibacter and have methane levels, but are actually asymptomatic. They don't necessarily have a problem, and methane production is not a damaging phenomenon in the colon necessarily, unless they're really overgrown. It can be constipating, but not everyone will be constipated. So the issue here is that methane will be produced wherever hydrogen producing bacteria are located, because methanogens require hydrogen atoms to produce methane, and that is a really important concept. Because you can have a rise of methane, as we just saw in the previous test result, which indicates that also hydrogen-producing bacteria were there in order to feed that hydrogen to methane. So SIBO that's positive on a methane or methane rise really does mean that there are hydrogen-producing bacteria in the small intestine as well. But when we see a methane level that stays high throughout the entire test and never reaches levels where we would consider that to be positive for SIBO, is a different phenomenon. So because hydrogen-producing bacteria are throughout the digestive tract, and so are methanogens. So this is really the importance of differentiating these two test results, which we'll see. So just to go back one slide, this is a SIBO positive methane test result where we definitely see a rise that's diagnostic for SIBO. And when we see this test result, for example, where we see methane starts at 32 and then it sort of waffles around By 100 minutes, it's gone only up by about 5 parts per million over the lowest preceding level. And then here we are in the large intestine. This is what's called IBS-C methane positive if the patient is constipated. If the patient is not constipated, they may not need treatment. That may not be their issue. So it's a really important concept to differentiate, because a lot of labs will report this as positive for SIBO, and I would disagree with that. That's a different phenomenon. I think I skipped a slide here. And so this quote here is actually from the North American consensus. They state that until further data is available, we suggest that a level of greater than 10 parts per million be considered positive for methane on a breath test, which was previously, for those of you who've been in the SIBO circuit for a while, you've heard this before, that methane shouldn't be higher than 3 parts per million if your patient is constipated. That's now been revised to 10 parts per million. And SIBO test reports methane rise of 12 parts per million by 100 minutes as positive for SIBO, and presence of 10 parts per million as positive for methane, as I've just demonstrated. So in this case, what we're saying here is, so if we go back to this case right here, where we have no rising at all, where we just see sort of like a very small rise, it's all reported as negative. And then additional report or additional notes, you can see here, is that though a rise of 12 parts per million of methane in the first 100 minutes is required for a positive SIBO result, methane measurements greater than 10 parts per million can be considered positive for methane and can be correlated with IBS-C if constipation is present. So important concept for practitioners out there. This is also another really important concept that you can see shifting methane and hydrogen levels on retest. So high methane followed by high hydrogen on a retest. This is frequently seen and not cause for alarm. And let me explain that a little further. I've just said before that methanogens require hydrogen in order to produce methane. So when you're in this first case, we see this person is very positive for SIBO, has a lot of methane production. So the practitioner started with methane treatment or methane SIBO treatment, and then retested. And what do we see here? We see that levels of methane have come down quite nicely, but now we see hydrogen go up quite dramatically. And that is because for every methane molecule, you require 4 hydrogen. And that's why it's CH4 is methane, meaning that 4 hydrogen molecules are required. So it's understandable as to why all of a sudden you are shocked. You think, oh my God, this person is worse than ever before, but that is not the case. You've done a good job with reducing that person's methane, still needs a bit of work, but now you need to concentrate on hydrogen. Unfortunately, looking at levels of hydrogen is not quite as predictable in terms of how many rounds of antimicrobials you need. So that is always a little bit less predictable. This is an example of a positive fructose result. So the same, because it's a substrate for SIBO, you can see how high this goes. I mean, this is a tremendous amount of fermentation going from 4 to 108 in 60 minutes. So this is sometimes cringe-worthy when we see that, because it's quite a lot of gas that's being produced. Versus, in this case, if we look at this where we have a hydrogen of 7, it goes up to 22, and then goes back down to 19. So because we actually measure fructose every 20 minutes versus other labs that measure fructose every hour, you can see here how easy this little blip of fermentation would have been missed if we had done it every hour. So it's important to measure these samples correctly, and every 20 minutes if you're using it for SIBO testing. And here is an example of a higher baseline, where we start with a reading of 21, and then it sort of drops, and then it waffles around again down here. This could potentially mean that the person didn't really prepare adequately for this test, because we'd like to see a little bit of a lower reading for hydrogen than 21. Sometimes it does happen and the person swears they've done everything absolutely correctly, and there are other extenuating circumstances that could produce this. But the most likelihood is that this was a bad prep diet and you need to ask your patient. This is an example of somebody who really messed up on their sampling. And so the way to assess this is to look at the carbon dioxide column here. Anything over 1.5 is accurately sampled. Anything below that is inaccurately sampled, meaning that they possibly punctured the tube prematurely and contaminated that sample with room air. So what we're seeing here are all these samples are below 1.5, and so we know that those samples were inaccurate. And you can certainly see here that this is reflected in both hydrogen and methane readings. That's why it's really important to ask your lab to also report carbon dioxide on your reports. Now, the infamous flatlining, and I say infamous because there is a lot of discussion around flatlining, meaning that it is always hydrogen sulfide, and that may or may not be the case. So hydrogen sulfide, as I mentioned, is the third gas that's currently not yet measured by the breath tracker that almost every lab is using that's out there that does any sort of SIBO testing. So what we're looking for here, as is demonstrated in this sample, we see a lot of flatlining in both hydrogen, where we start with 5 and then it goes down to 1. So single digits, and not until the 180-minute mark do we see any marginal rise at all. And the same with methane here. There's nothing really happening, and certainly also for the combined. So hydrogen sulfide is a gas that uses even more hydrogen molecules or atoms. I think it's 5 hydrogens per hydrogen sulfide. So it siphons off even more. So this is a possibility that you have a patient that is much more populated with hydrogen sulfide producing bacteria in their small intestine, and those are bacteria like Desulfovibrio species and Bilophila species. So there's different bacteria that produce different gases. But you might also have somebody that's just not fermenting lactulose very well, and that is a possibility, as you've seen before on these test results, is that lactulose is not always fermented by all bacteria. Certainly in the large intestine, we do expect a rise of hydrogen if that person has sufficient bacteria there, because there will always be some bacteria that should be fermenting lactulose and producing some hydrogen in the large intestine. But you can consider hydrogen sulfide, especially if your patient is diarrhea dominant and has the classic sort of rotten egg smell, flatus, and also sort of breathing or burping rotten egg smell, sort of gaseous emissions. And if you don't have that, it doesn't mean it's not hydrogen sulfide, but it gets a bit more complicated in that scenario. But this is something that I would consider with this person if the symptom picture fits. This is what we do expect in a patient, is that by about usually 120, but in this case more 160 or 180 minutes, we see hydrogen rising as that substrate reaches the large intestine. This is why we do a 3-hour breath test, to ensure that we see something happening in the large intestine. So this is normal. Now, retesting. This is the famous sort of algorithm that Dr. Siebecker and Dr. Steven Sandberg-Lewis have created years ago, but I want to draw your attention down here to the retesting area, where once your patient has gone through the treatment of either herbal antimicrobials or antibiotics with different diets, and if your patient comes back and says, wow, doc, you're a genius, I'm 90% improved, you don't actually need to retest that patient. You can manage them, but if they have a partial improvement, it's highly suggested to retest to ensure that you are actually using the right treatment, or if you've cleared SIBO, that you're looking at a different underlying diagnosis. So this is sort of an important concept to retest if you only get partial improvement. And how long should you treat? Well, this is not really a presentation that's going to be talking much about treatment, but typically what we can expect with methane gas is that a round of herbal antimicrobials, which lasts typically 4 to 6 weeks, you can expect methane to be reduced by 20 to 30 parts per million. So if you've got somebody that has methane levels 60, 70, 80, 90, you can sort of roughly estimate that it's going to take longer than 6 weeks. Also, a 2-week course of antibiotics, typically either rifaximin, usually rifaximin and neomycin together. That's the classic methane-dominant prescription. Hydrogen gas, unfortunately, is less predictable. In other words, if you're positive, you don't really know. You may need 1 round of herbal antimicrobials or rifaximin, or you may need more than 1. So if somebody has high levels, you can expect them to be on treatment for a good 2 to 3 months. And also with antibiotics, often 1 course is not enough. Okay, this is something I've mentioned throughout this presentation. If lactulose breath test is negative, but you think it is SIBO, it's either SIFO or small intestine fungal overgrowth. And the reason I'm not talking about this on this webinar is that there is no breath test for SIFO. You might want to, so if you have a negative breath test with lactulose, you might want to confirm that with glucose. Let's have a look at an example of insufficient reporting. This is an example of a different lab. And what they've done here is a few different things that I'd like to point out. And this is just as a teaching tool. This particular lab used 20 grams of lactulose, which is twice as much lactulose. And with that dose, we can expect a sensitive patient to experience diarrhea and therefore more rapid transit. So in this case, it was reported that diarrhea occurred. Also, you can see here that we have 20, 40, 60, so every 20 minutes from baseline, that's all good. And then all of a sudden we go to half an hour, and then we go to another hour. So it's kind of very confusing reporting. And also you have no idea if all samples are viable because no carbon dioxide has been measured. So in summary, breath testing is an excellent tool to assess and manage SIBO. There are differences in labs in terms of prep recommendations, testing parameters, length of test, and collection devices. So given this presentation, which will also be made available, you'll get the recording, but it'll also be in this practitioner section on sibotest.com. You can always review this. You might want to ask your lab these questions. If you get a negative lactulose test result, consider following up with another substrate to confirm if the patient has classic SIBO symptoms. Also, if you want to learn more, there certainly is a lot of materials on sibotest.com. We also have SIBO Fundamentals classes and Master classes, as well as monthly group mentoring and case reviews with yours truly. And coming in November, we also have a Gut-Brain Axis Masterclass with Dr. Bradley Bush. And this, another great resource for you is the SIBO Doctor podcast, where I'm in conversation with other SIBO experts, and you can follow the link here or subscribe on iTunes. So now I will have Emily, our operations manager, Emily Sugars, who's aptly named for SIBO test, ask me any questions that have come through. Okay, so far we have not had any questions. I'm still going to, if anybody has any questions, please enter them in the chat box. I probably should have said this at the beginning, but we're here to answer your questions regarding breath testing. if you don't feel like typing, you can also unmute yourself and ask the question directly. We will be here for another 5 minutes or so and waiting for some questions. But if you are not wanting to ask any question, I really want to thank you for this opportunity to teach you a little bit more about breath testing. And I really wish you very well on your journey with helping many, many patients achieve digestive health.
Okay, we have one question so far. You said that the kit contains 75 grams of glucose. That's 1 gram of glucose per kilo. What about heavier people?
Okay, that's a good question. What about heavier people using 70 grams? Usually 75 grams of glucose is sufficient. It's a heck of a lot of glucose. And because we're really testing the proximal small intestine, that is usually a sufficient dose. Anything over that is really going to make them quite symptomatic very often.
Okay, next question is, when you say if lactulose is negative, it could be SIBO confirmed with glucose. Could you elaborate, please?
Okay, so this is always a challenge for practitioners when the test result comes back negative, but the presentation of your patient is really suggestive of SIBO. The fact is that many patients, something around the order of 20 to 25% of your SIBO patients have concomitant SIFO or small intestine fungal overgrowth. And then there's another good 20-25% who really only have SIFO or the fungal overgrowth without SIBO. So when you get a negative test result, it's possible that they actually just have this fungal overgrowth. But it's also possible that the lactulose was not fermented. So if you did a SIBO breath test with both lactulose and glucose, and both of them are negative, and yet the patient complains of these symptoms, it's very likely that they have an element of SIFO. And there is no test for SIFO other than a small intestinal aspirate and culture, which is, of course, extremely difficult to do in the office.
The next question is, Dr. Siebecker talks about not using any laxatives at all for 5 days prior to retesting, including magnesium. What are your thoughts on this?
Mm-hmm. So the idea here is to reduce any sort of motility. But the thing is, with magnesium, you're not really increasing motility like some really harsh laxatives. You're just drawing water into the colon, and it's not a stimulant at all for the small intestine. So I'm a little bit more comfortable to use magnesium oxide. It might not be working for a patient. They might just have to be constipated for the duration of the prep diet and the test. It's about 3 days. And not using laxatives during that time. And you can always customize this depending on the severity of symptoms. If the person says there's no way I'm going to stop laxatives, you might want to just say, okay, well, let's see what we find with testing and what test results we got, because very often people still come up positive.
And just following on to that, is magnesium citrate okay?
Yeah, I mean, magnesium citrate is fine. Also more of a relaxant, but you really need that sort of drawing water into the colon. And if your patient has good results with magnesium and has not loose bowel movements, I think there's room for using magnesium. Good question, though. Very good question.
It is not quite breath testing, but if hydrogen sulfide is high, is there anything that can be done about it? Will antimicrobials help?
Yes, so hydrogen sulfide is a little bit of a different animal, but they are also responsive to antimicrobial therapies. One of the concerns about using certain forms of berberine is not using berberine sulfate, because it can be a substrate for hydrogen sulfide and producing bacteria. And also it makes it a little bit more tricky, and that's probably beyond the scope of this webinar in terms of what treatments to go into. But I would treat it sort of similarly as a lactulose positive breath test with antimicrobials, but you need to be more mindful of dietary influences and contributions of sulfates or sulfur and sulfur-containing products like wine, for example, which they shouldn't have anyways when they're doing the SIBO protocol. There's also some evidence to suggest that desulfovibrio and bilophila, the main sulfur-producing, hydrogen sulfide-producing bacteria, thrive in an environment of very high animal protein and animal fat, which is, of course, some people have limited themselves to this type of diet on SIBO. And so, again, you as a practitioner need to evaluate that patient.
Why do you recommend retesting after 1 day of stopping herbs? Why do you not wait longer than this to retest?
Yeah, so this was the old recommendations, is that we actually wait 2 weeks to wait for a regrowth, basically. But what the consensus has now confirmed us is that we actually want to see if the antimicrobials or antibiotics were successful and that everything has been eliminated, so that when symptoms then arise after that, we can see how quickly somebody has relapsed. And this is definitely a lot easier to do for patients. And oftentimes, I've seen this certainly in my practice, where somebody was doing much better, and then in the 2 weeks of waiting, they started to become symptomatic again. And that's significant in order to assess the rate of relapse. So we now recommend that you retest as soon as possible after antimicrobials.
Are the values different in children? What ages can you use this test on?
The values are the same. The substrate amount is slightly different, obviously, for glucose. And we can start testing children as soon as they can control the breath, because it's all about controlled breathing into the sample collecting tube bag.
If someone did a prep diet for 2 weeks, could this lead to a false positive?
A prep diet for 2 weeks, that would be pretty tough to do. I mean, some people are self-restricted to this degree. I have seen that a lot, but to have no vegetables at all, we would never recommend the prep diet to be done for 2 weeks. And there may be some confusion around elemental diet, I'm not sure, but elemental diet is a completely different situation. This is just the prep diet for the test. You wouldn't have any false positives because the idea of the prep diet is to reduce bacterial fermentation prior to testing. So if you've done that for 2 weeks, you have reduced bacterial fermentation, and a dose of lactulose or glucose or fructose should stimulate enough bacterial fermentation if you do have SIBO.
Can we choose just a glucose test if the patient has had their lactulose test done at another lab?
Good question. We wouldn't recommend that because for the examples that I've given you, there are different test ways that labs assess tests. So we always recommend that if we're going to run it and give you an accurate assessment, then it's recommended that you do the lactulose again. However, the person certainly can just order a glucose test. That we are a self-ordering facility where the patient can order whatever lab test they want. So that is possible, not recommended though.
Okay, so does the prep for endoscopy preclude accurate measurements of small bowel aspirate for measuring small bowel bacteria and fungi? And is there such a recognised normal range for such a test?
Okay, very good question. So usually when people get an endoscopy, there are certain prep guidelines for that as well. But if they're doing it for the purpose of an aspirate, and I often recommend people when they go have an endoscopy for gastroesophageal reflux disease, that they request actually from the gastroenterologist to have a sample taken so that a culture can be done, because you want to see what bacteria are there and if fungal elements are there as well. Let me see if I've actually answered this question. No, there are no. Oh, well, actually, I should say anything over. So SIBO, by definition, is greater than 10,000 organisms per mil of chyme in the small intestine, and it's down to about 0 in the first part of the duodenum, and it goes up to, I believe, about 3,000 at the end of the duodenum. So anything greater than that would be definitive of SIBO if it's greater than 3,000 or so organisms per mil. So that's what they have to look at. And they, I think that was the question, yeah? Let's see here. My question, I think, let's see here.
On the next one.
Mm-hmm.
So, can viruses in the gastrointestinal tract also produce gas?
Not to our knowledge, no.
Next question is, if someone took 2 days prep to diagnose SIBO because they were constipated, but then after treatment and using mild laxatives has more regular bowel movements and is not constipated leading up to retesting, do they still need to do a 2-day prep for consistency?
Great question. No, it's always just what's happening now. So if the person is not constipated, hasn't been constipated for the past 2 weeks or so, you can just recommend a 1-day prep diet.
If a client has yeast or on an organic acids test or stool testing, can we assume this is also indicative of SIFO if they have SIBO/SIFO symptoms?
No, because, well, actually, let me say that with less fervor, because yes, if somebody has an oats test or an organic acids test that shows very, very high arabinose and other yeast markers, tartaric acid, etc., it's likely, especially if they have small intestinal symptom and their SIBO test is negative. I think I'd feel comfortable as a practitioner to think that yes, indeed, they have SIFO. But on a stool test, the large intestine and the small intestine, even though we often talk about that the small intestine or SIBO is actually sort of like a migration of normal bacteria from the colon, it's actually much more likely that bacteria stayed there and sort of form their own environment, because the bacterial sort of profile of the small intestine is completely different from the large intestine. So those two are apples and oranges. You cannot compare, and you cannot really derive anything from a stool test about SIBO.
And I think that's everything. That's all the questions.
Fantastic questions, everyone. You can review this very soon. We'll send out the link. And as always, we appreciate your business and we appreciate your trust in SIBO Test, and we hope to see you in the future for other educational webinars.